Andrew Phillips. I'm a consultant gynecological oncologist at Derby Gynecological Cancer Centre, which is based at the University Hospitals at Derby and Burton. And I'm here to talk to you about, as discussed, a topic which is very close to my heart, which is ultraradical surgery and ovarian cancer, with the interesting twist of lights and shadows. So I don't have any disclaimers. The objectives really for this talk, I want to talk about four things. I wanted to really just talk about what the term ultraradical surgery describes. I want to talk a little bit about where we are and how ultraradical surgery has evolved and what are the benefits and ultimately what issues, if any, still remain. So first of all, what is ultraradical surgery? And why do we use surgery? So we've got two main factors which influence survival in advanced ovarian cancer. And those are platinum sensitivity and residual disease at the end of surgery. Okay, so surgery obviously influences this final one, and ultraradical surgery tries to move even more patients into that group where they have less disease left at the end of their surgery. And do we have any evidence for that? Well, this is probably where this all started. This is a randomized trial from Vandenberg back in 1995, where they took a selection of suboptimally debulked patients. They exposed them to some cisplatin-based chemotherapy for 3 cycles, and then they got rid of the ones which progressed in the interim. And then the remaining patients, half of them got surgery or thereabouts, and the rest got no surgery. And what they showed is that those patients which were exposed to a second surgical operation had an improved survival relative to those which did not. And that's probably the basis of evidence which really confirms what lots of retrospective studies had said prior to that point. But we know that surgery has a benefit in manipulating how these cancers behave. But where do we need to operate in advanced ovarian cancer? So I've decided to sort of, I want to put forward my evidence sort of with a bit of a UK bent, really. And these are 2 papers which came out from the UK at the same time. The first one's by Christine Fotopoulou on the left. And these are both their retrospective cohorts of consecutively operated patients. And they mapped out really where the disease was in these patients. And what you can see in Professor Fotopoulu's paper is that 97% or so had disease in the pelvis, similar amounts in the mid-abdomen, but critically, she had 83% of her patients had some disease above the greater curve of the stomach. Okay. The second paper by Turnbull changed this a little bit on its head. Okay. Now, this was their cohort of patients which had been treated during their ultra-radical surgery paradigm, but they split it up into what would have been the outcomes had we not have done some of these surgical procedures. So in group 1, these patients were treated, say, with just a hysterectomy and some form of a mental resection. And that got them a complete site reduction rate of 14%. A little bit got down to sub-centimetre disease, but the vast majority, there's 82% here, had volume greater than the centimetre at the end of their surgery, if that's the surgical approach they had adopted. In group 2, they moved into the mid-abdomen with some gastrointestinal resections. And again, the site reduction level was quite poor. Only 22% or so, 23% would have been completely site reduced. Sub-centimetre disease, a little bit more. But again, the majority of patients are still ending up in this suboptimal group. Okay. And it was only with their modern era, when they moved into operating the upper abdomen as well, that you really see the complete site reduction rate increase. So the utilization of surgery in the upper abdomen in their cohort increased their complete site reduction rate up to 54%, their sub-centimetre disease rate up to 34%, and actually now those larger volumes, suboptimal debulked patients, is now very much in the majority. And really, this is what ultraradical surgery is looking at disease around the upper abdomen, but it is quite poorly defined. So this gentleman here is an American lawyer who, in an obscenity case, said famously, I don't know how, I can't define something, but I know it when I see it. And we're a bit like that with ultraradical surgery. So in the UK, ultraradical surgery is defined by the National Institute for Health and Care Excellence along this line. So precise differences between these, let me just minimize this. These procedures are not particularly well known, okay, but the differences between standard surgery and ultraradical surgery consist of stripping of the diaphragm, extensive stripping, whatever extensive means, of the peritoneum, multiple resections of the bowel, but for some reason we're excluding localized colonic resections, liver resections, partial gastrectomy, cholecystectomy, and splenectomy. So it's definitely upper abdominal surgery, but there's a bit of a mixture of some other bits and pieces in here. Some degree of peritoneal resection, some degree of bowel resection. And the reason why this is a slightly bizarre concept in some respects is, let's take 2 example patients. So this is patient number 1, okay? They've had a hysterectomy, a BSO, an infracolicommentectomy, some peritoneal strippings, but not extensive, a rectus sigmoid resection, small bowel resection, some ablation of their diaphragmatic nodules, and some resection of some bulky paraortic nodes. And the other patient is going to have a hysterectomy and a non-block supracollocomentectomy and a splenectomy. Now, according to that criteria, this patient here is not ultra-radical, okay? And this patient is ultra-radical. But I put it to you that on balance, this patient here who's had their omentum hysterectomy and their spleen removed is probably going to have a better post-operative period than this person here with 2 bowel resections. And that was really the focus, what we looked at in relation to this paper published in BGOG, entitled "The Nice Classification for Ultraradical Surgery Does Not Meaningfully Predict Post-Operative Complications." Okay, study. And we looked at the population of where I was at the time, which is in Birmingham, and we split up all the surgery performed in relation to a number of different ways of defining surgical approach. And we had surgical approaches defined by procedures. You know, do you do ultraradical surgery, or have you done a bit of an operation on the bowel? And then other definitions looking at sort of numbers of procedures ultimately. And what we showed is that compared to standard surgery, this nice definition of ultraradical surgery only really picked up 58% of complications, which gave a relative risk of major complications of about 4.65. And that was an inferior definition than just saying, has the patient had an operation on the bowel, which picks up 72% of complications with a relative risk of 4.69. And certainly, this definition as put forward for ultraradical surgery was less useful than definitions which were really highlighting much more complicated surgery. You know, 2 or more bowel resections had a relative risk of 7.73, a diaphragmatic stripping and a gastrointestinal resection at 5.57, and also a Letty's high surgical complexity score came in at 6.12. Now, the Letty's surgical complexity was a very different way of defining surgery compared to a so-called ultra-radical definition. And really, you get a point score for the number of procedures you do. If you don't do a lot of procedures, you do a low surgical complexity operation. If you do a large number of procedures, you have a high surgical complexity operation. And really, there's this interplay between all these different terms, okay? Surgical complexity, not a lot of surgery, quite a lot of surgery, ultra-radical surgery, more pelvic surgery, more upper abdominal surgery, and the site reduction which you gain from that. And that makes it very difficult to interpret lots of the papers which are published, because the way these things all interplay is quite unclear in a large number of papers. You could have a low complexity ultraradical surgery which completely gets rid of all disease. You can get an intermediate surgical complexity with standard surgery which, you know, does something different. It is all a little bit unclear. And really, this was our conclusion from this talk, which was really that defining cytoreductive surgery in a meaningful way really just remains elusive. And actually, what we're describing in relation to ultraradical surgery is really our progression from sort of pelvic confined gynecologists to gynaecological oncologists and more surgical oncologists, which are able to treat the entire abdominal distribution of disease. Okay, but such terms as ultraradical surgery are quite emotive, they're often poorly defined, and probably do very little to quantify the risk for patients. But ultraradical surgery is there. And I think what we're going to take it to mean for the purpose of this course, the rest of this talk, is upper abdominal surgery or some form of extensive mid-abdominal surgery. So where does this come from? Now, I'm going to start back in 1990s with this paper by Guidosi, okay, which is a fantastic paper. Published 1990, it's a 10-year review of 30 patients which they did extensive surgery on, okay. These are quite young patients, age 56. And what is interesting to note is that obviously, on the grand scheme of things, these patients didn't have particularly extensive surgery compared to where we are now. You know, pelvic surgery, omentum, the majority had some form of probably what was heading towards a total colectomy, you know, a bit over a third having a small bowel resection, you know, fairly standard numbers for splenectomies. They had a couple of slightly bizarre procedures, which happen quite often though. Partial resection of the urinary bladder is really uncommonly needed in advanced ovarian cancer. We can now strip the disease off the bladder, meaning you don't actually go into bladder, don't need to resect any bladder. Same thing with nephrectomies. You can strip the Morrison's pouch peritoneum up and therefore spare the performance of something like a nephrectomy. So I think this is a study which is indicative of the surgical techniques at the time to a certain degree, where the ability to strip and remove disease, diathermy treatment was perhaps less effective then than it is now. So actually these patients ended up having quite a gross resection of their disease in their pelvis. And the results out of this were less than ideal. All right. The mean blood loss was about 3 litres. 33% of the patients went into DIC. You know, the cytoreductive outcomes are of their time, but not particularly great. And 43% had severe post-operative complications, with 7% dying within 48 hours of surgery. And Godozzi quite reasonably states that in their own unit, the 43% significant complication rate has dampened our enthusiasm to perform multiple organ cytoreductive surgery. And I can entirely understand that. That would dampen my enthusiasm to do multiple organ cytoreductive surgery. But things changed and they moved. And I've blended in a few standard procedures in here as well. But ultimately, Aletti started publishing on rectus sigmoid on block with pelvic peritonectomies. Dennis G around sort of 1998, 2002. Someone mute there. Thank you. Dennis Chi started publishing on diaphragms with cohorts around 1998, 2002. Spleens by Chen came in around the same sort of period, then liver, then finally paracardiac lymph nodes a little bit later, 2008, 2011. And people were looking at how to perform these procedures and perform them safely, and then actually started to associate that with improved cytoreductive outcomes and then demonstrated improved survival. And that all came to a head with this paper by Dennis Chi, which is really a seminal paper entitled Improved Progression-Free and Overall Survival in Advanced Ovarian Cancer as a Result of Change in Surgical Paradigm. He is looking at cohort, and it's just behind my screen, I can't quite see it, but around the sort of the turn of the century. And they took two cohorts at Memorial Sloan Cancer Cancer Center. The first cohort back in 96 to 99, where they didn't do any upper abdominal surgery. And then the second cohort, which is 2001, 2004, where they started doing upper abdominal surgery. Now, I think the important thing to take from this paper, this is not a move from all patients having no upper abdominal surgery to all patients having complete upper abdominal surgery. Dennis G has selected his patients very carefully, all right? So this is a study looking at the utilization of upper abdominal surgery in certain situations, because his rates of diaphragm stripping a little bit less than he'd published now, 35% or so. Splenectomy rates, he's now around 20%, he's published about 12, and so on. But the utilization of surgery to remove disease in the upper abdomen in this cohort, okay, improved survival. And indeed improved the optimal cytoreduction rate from 46% to 80%. However, in the UK, things weren't quite as advanced. So in around the same time scheme, this paper was published. Does aggressive surgery only benefit patients with less advanced ovarian cancer? Which is an analysis of a chemotherapy trial called Scott Rock. And there are lots of papers in the UK around this sort of time looking at this sort of issue, saying, oh, actually, your surgery doesn't matter. It's all disease, the disease behavior, which influences your mortality. But this is the quality of surgery we were doing in the UK at that time. Okay, so here are these stages across here in this study: stage 1C, stage 2, stage 3, stage 4. And what you can see is that in the UK, stage 1 cancer is operated in 90 minutes. Stage 2 cancer at this time was operated in 90 minutes, as was stage 3, if not stage 4. And if you compare that to, this is mostly European centres, actually there's a much greater range between in the operating times as the stage increased. Okay, all right. And that's because I suspect all these patients are having the same operation. They're having a hysterectomy and they're having some form of mental resection. And that perhaps explains why the cytoreduction rate was 28% in the UK compared to 39% or 40% in Europe. And what's interesting to note is that of these patients, 20% of the patients in the UK population had stage 1C or 2 disease, which should pretty much be cleared with fairly limited pelvic surgery. Okay, so out of the remaining 80% of patients, that's where our remaining 8% comes. So at this point, at the UK, at the same time, Dennis Chi is showing the abdominal-wide surgery, the UK cytoreduction rate for advanced ovarian cancer was about 10% or so. So you would have thought things would improve, but it hadn't. We're now going to leap forward to 2013. This is a surgical practice of UK gynecological oncologists. And looking at what procedures would perhaps be required in their patients. And actually what this study showed is that out of all the pooled and surveyed gynecological oncologists, maybe 0.6 or 1.4% patients would be getting splenectomies. We know that number should be somewhere between about 15 to 20%, and diaphragmatic stripping was extremely underused with 2.7 to 5.7. Okay, so the quality of surgery in general at that point still very poor in the UK. But centres started developing, and there are a couple of major centres which he pushed this forward. Birmingham, which I came from, Gateshead, but also Imperial College, who employed a wonderful surgeon called Professor Fotopoulou. And this is a recent paper which she has published comparing her performance of advanced surgical procedures with that of another UK centre. Now, in her centre, what you can see here is 14% of patients are requiring splenectomies, and 57% or so are having diaphragmatic surgery. Okay, all right. In our other centre, which is just down the road but refers all their patients in for chemotherapy at the same hospital, none of these procedures being performed. So there's a wide variation in the utilisation of upper abdominal surgery. And the survival between centre A and centre B was significantly different between the two. But I'm not going to show you their numbers because I'm going to show you my numbers. So this is the Derby cohort. So we introduced ultraradical surgery in about sort of 2015 or so, and this was our survival beforehand. Okay, all right. Medium overall survival for the total cohort, which we operated with, came in at 31. And after introducing an ultraradical approach to surgery, that increased to 36. However, if you look at this by separate age groups, if you take the group of patients which are all aged less than 70, of which the majority are starting to be imposed by a more radical surgical ethos, the improvement in survival is much more stark, going from 31 months to 40 months, and with 4-year survival coming in, we're going from 31 to 49%. Okay. So ultraradical surgery works. All right, and actually you can get some really wonderful results. Now this is the LION trial, which was published in the New England Journal of Medicine, which is essentially looking at whether we need to perform a systematic lymphadenectomy at the time of our debulking surgery, or just resection of bulky lymph nodes. Okay, now they've been a little bit cheeky, okay, because the paper excluded everyone who hadn't been completely cytoreduced as part of their methods to try and identify which people would truly benefit. But what you can see is significant amounts of splenectomies and a sort of a reasonable amount of diaphragmatic stripping, okay, in order to achieve a very good cytological outcome. And if you get that in this cohort, their median survival is now looking at 60 to 72 months or so, which is an excellent outcome. So the light of ultraradical surgery, it works, okay? It improves our cytoreduction rates, and that in turn improves our survival. However, there are some issues. First issue, cost and resources. So one of my fellows is looking into this at the moment, okay? This is how much a staging laparotomy costs in the UK. It's about £7,500. An ultraradical operation is about £20,000. Okay. Now, all of those paired into significance, if you compare them to the ones for olaparib, which we discussed previously, it's about the same cost as bevacizumab. But ultimately, if your surgical budget is fixed, you can do 2.5 staging laparotomies, okay, and perform substandard surgery, or you can do 1 ultraradical operation. And actually, it's a little bit worse than that, because not only is there a monetary cost, there is a opportunity cost. So before the era of ultraradical surgery, this is what one of my colleagues would have on his list: to do an interval debulking and staging laparotomy. Okay, that would take him round to just after lunch, and then do 2 laparoscopic hysterectomies in the afternoon. And he would do that on his day list with a registrar and an SHO. In the new era, we do 1 interval debulking, and we have to extend our list. Okay, by the time they've got all the anaesthetic lines in, we get started at about maybe 10 o'clock, and we finish maybe sort of 6 o'clock or so. Okay, and when the service was first set up, we now did it with 2 gynecological oncologists. My college, which set up the service, did it with a consultant gynecological oncologist, a consultant colorectal surgeon, a consultant hepatobiliary surgeon, a registrar, and an SHO. So not only do you now need to find some extra surgical space to put your staging laparotomy or total laparoscopic hysterectomies as well, all right, you also have lost a colorectal clinic and a hepatobiliary clinic. All right, and these are all resources which are slightly scant. So beyond the monetary cost, there is a opportunity cost which is associated to this surgery. Second issue, identifying disease, reporting outcomes, and quality standards. So I'm going to make an assumption, all right, and that assumption is that across the world, the distribution of disease and ovarian cancer should be fairly similar. Now, I know that different racial groups respond to different chemotherapies in slightly different ways, okay, but on balance, I'm going to assume that high-grade serous ovarian cancer manifests itself in the advanced stage generally in similar ways across similar populations, okay? And last year, I had 2 comments which were made to me, which were quite interesting. The first one was from a subspec trainee in a separate UK gynecology centre, who said, our patients never have splenic disease. That's very interesting, okay? They're planning on coming up to see us to see how to perform this surgery. And I thought, well, either you are screening out patients, okay, for having surgery who've got splenic disease, or you are not looking carefully enough to see if they have disease. And at the other end of the spectrum, I had someone who said, oh, everyone has got diaphragmatic disease. Well, various randomized trials don't quite support that. So that implies that they may be over-treating diaphragmatic disease, because treating disease depends on a number of factors, all right? It depends if they've got it there. It depends if you can identify that they've got it there. And it depends if you can identify that you've got the skills to remove it. And not only do you need to have the skills to remove it, they need to be fit enough to be able to have it, okay? And there's so many variables in relation to all of this. This is a study which we did at Birmingham, just a small one, looking at preoperative CT and intraoperative assessment of disease on the spleen and the diaphragm. Okay, and what you could see that CT scanning picked up a certain amount, and if they thought there was disease on the spleen or on the diaphragm, they pretty much had it. One went in and removed it, but actually it missed a large volume of disease, okay, which we picked up intraoperatively. Now, this intraoperative assessment is only as good as my mentors, Kavita Singh and Janos Baliga. It may be the case that we were underestimating, or they're underestimating the amount of diaphragm disease which was prevalent there, okay? So we need better ways to be able to identify and be able to really benchmark how these things, how procedures should be performed, because you end up with this. So this is a sort of part of a slide looking at the performance of splenectomies, and splenectomy is a really good judge of surgical assessment, I think. And you can see that the percentage of splenectomies which are performed across these cohorts varies widely, and that's what I've put in this graph here, plotting splenectomy rate up the side and complete site reduction rates along the bottom. And you can see some interesting things. And I want to draw your attention to these little groups down here, first of all. So this group here forms no splenectomies. Okay, this one does 4% splenectomies, and they're claiming a complete site reduction rate of between 50 and 60%. Okay, and up here, this group does 35% splenectomies, and is claiming a site reduction rate of about 52%. Now, all these figures may be influenced by a number of different factors, what we discussed before, but also the utilization of neoadjuvant chemotherapy or primary surgery, or exactly what stage. But in balance, these are quite sizable variations in the outcomes, more than I would perhaps expect if this was just due to the treatment approach. At the other end of the spectrum, if we take this group down here, so they're performing about 12% of splenectomies, and they're getting a 25, 26%, maybe a little bit higher than that, complete site reduction rate. At the other end of the spectrum, these people over here, okay, are performing, what's that, 13 and 14% splenectomy rates, and are claiming an 80 or 90% complete site reduction rate. So it is really difficult to make sense of what the prevalence of splenic disease is in ovarian cancer, because we don't do studies removing all spleens in all patients. So we rely on the surgeons to be able to report it, and rely on the surgeons to be able to report the cohorts which they're taking these patients from accurately, so we can actually make informed decisions for these patients. On a similar line, complications, my third darkness. So this is the document which I talked to you about, which introduced ultraradical surgery in the UK, ultraradical extensive surgery for advanced ovarian cancer. Published 2013. You don't need to read all this, but this is the one paragraph which talks about mortality. All right, what you need to just notice is that there's lots of 1s and 3s for their various percentage rates of dying following their surgery, which is fine. However, so last night I put into the NSQIP surgical risk calculator just some numbers in relation to splenectomy, okay, not ultraradical surgery. Splenectomy is lots of other things, just performing a splenectomy. So this is a risk calculator from the States, which has looked at patients which have actually had surgery, looked at their premorbid comorbidities, and then has told you exactly what's happened to them. So assuming these patients got disseminated disease in ascites, if they're aged less than 65 and independent, the mortality rate, which it quotes, was about 0.6% just for the splenectomy. But you don't need to tweak your numbers very much to suddenly start getting elevated mortality rates, okay? Age 65 to 74, that's a fairly good range for ovarian cancer. Make them a little mild systemic disease, maybe some diet-controlled diabetes, some tablet-controlled hypertension. They've now got a 5% risk of dying of this operation. This is just doing a splenectomy. Make them a bit older, okay? Don't change their comorbidities. You're now up to 12% mortality rate. And that's very important, because this is a distribution of ovarian cancer in the UK. I think now actually the 75 plus group are our most populous group, okay? And just for reference, the studies which I've mentioned to you before with their mean ages came in at 56, 61, 58, 57 and 60 also. So one just wonders if quoting the mortality rates from these centres which perform this surgery on predominantly maybe, let's say, slightly younger women may not be applicable to slightly older women, but we don't really have good evidence to be able to inform these patients about whether they should undergo surgery or not. On a similar line, we've got issues around quality of life. Now, I've given you a 30-year history really about the development of cytoreductive surgery or ultraradical surgery. But why does quality of life matter? Well, patients might not want the treatment which you're offering, okay? Knowing what's going to happen to them allows them to plan for the future, and other factors are really important beyond just survival. You know, how are you going to be physically? Are you going to be able to work? How's your mind going to be? Are you going to be able to engage with your family and friends? Okay, so gains in survival might be offset by loss of function. I think we can all think of scenarios where you would not want a procedure if the gains are perhaps mild, okay, but the risks are absolutely potentially catastrophic. Okay. So one of my colleagues did a systematic review recently, which published in the International Journal of Gynecological Cancer, entitled Quality of Life Outcomes Following Surgery for Advanced Ovarian Cancer, a systematic review and meta-analysis. And they found about 10,000 records, and they removed some duplicates. And finally, when you whittle all the way down the entire process, they ended up with 5 studies which had some meaningful quality of life data. Okay, and out of those 5 studies, they had 1,000 patients, but they had quality of life data for 900 of them, but the attrition rate was very high. And by the 12 months down the line, they only had 49 of those patients still releasing quality of life data. Okay, and the conclusion which they had to draw from this paper is that there's just insufficient evidence on quality of life outcomes on patients undergoing extensive ultraradical surgery compared to those undergoing less extensive surgery. And these quality of life outcomes matter to patients, but there's very little evidence which we've got to inform patient choice regarding the extent of surgery. But this is the big problem with ultraradical surgery, okay? And I'm a strong advocate of ultraradical surgery, but this is a significant issue, the patient denominator in published studies. So why do patients not get surgery? Well, they die because they're going to get surgery, okay? Might die before they don't get chemotherapy in a number of cases. They don't want the surgery, okay? Or they're unfit for the surgery. So this is a study which we did at Birmingham, which was published in Gynecological Oncology a couple of years ago. And here we just played with the complete Birmingham cohort. The UK is quite good with the NHS in so much that all patients, on balance, all go to their central hospital. So you have a good handle that's all patients which are being referred into a central hospital, okay? They don't get taken off in other directions. And they don't particularly engage, especially for ovarian cancer, with the private sector in the first instance. So the UK, especially in, say, a place like Birmingham, where there's no real other suppliers of treatment in the nearby locality, will give you a good cohort of all patients which are coming in. And what we did is we split up these patients by treatment outcomes. So in the first group, we looked at patients undergoing primary debulking surgery. Okay, now the thing I should say about Birmingham is that we tended towards, at that point, a neoadjuvant chemotherapy approach. So the patients which got primary debulking surgery, okay, may well have had low-grade disease. They're probably extremely fit, or they have had surprise findings at exploratory surgery for presumed lower volume or earlier stage disease. Okay, so this little cohort of primary debulk patients is actually quite a select cohort of primary debulk patients. All right, and the survival is fantastic, coming in at 54 months. But then we had another group. So in group B, we've got all the patients which had primary debulking surgery, as well as all patients who had interval debulking surgery. And our median survival drops now down to 38 months. Start adding in all those patients which both had primary debulking surgery and interval debulking surgery, and were also assessed for interval debulking surgery, but we didn't want to give it to them. We're down to 35 months. If you add in all patients having any treatment for ovarian cancer, 33 months. If you look at the total cohort, all right, the survival drops down again to 30 months. Okay. So the denominator which these patients are coming from is vital for you to make an interpretation. Had I just published the primary surgery and said primary surgery is fantastic, ignoring all the other patients which had interval debulking surgery, and that was rolled out into these patients which perhaps, I don't know, weren't even fit for chemotherapy, the survival was likely to be relatively poor. And this is important. So as part of that paper, we did a literature review and looked at a year's worth of ovarian cancer papers and just had a little look to see who released their patient denominator to enable things to make things make sense, and if they did the survival. And what you can see for the vast majority of papers, there is no comment on the nomination data, which is revealed. We obviously did, and actually Andreas Dubois had 2 papers, I believe, which also published it, which is useful to know. But this is important because people will generate guidance and approaches to treating patients off the basis of the best evidence which is available, which for ovarian cancer quite often is actually non-randomized study, retrospective cohort studies. Okay, and this is an update of the European Society of Gynecological Oncology criteria for advanced ovarian cancer surgery. Now, Derby is an accredited centre, one of the 7 areas in the UK which has been recognised for advanced ovarian cancer surgery. And the European Society of Gynecological Oncology look at a number of different factors. They look at systems and processes, and is your pathology reporting correct? Is your surgical reporting correct? Do you have the facilities to be able to deliver high quality care? But really what the crux of they're getting down to, okay, is this. They want to have a high cytoreduction rate, okay, and they want to have a high proportion of primary surgery patients, okay, because that is what most of the evidence has said is the best way to get the best outcomes for your patients. So the extrapolation of this is, if you can, all right, with a reasonable complication rate, you should put all patients in for primary surgery with maximum effort to remove all surgery, okay, remove all disease. And then you get this. So this is a paper which is in press at the moment in gynecological oncology, all right? It comes from a sensible centre in Sweden by Henrik Falconer, entitled Ultraradical Upfront Surgery Does Not Improve Survival in Women with Advanced Epithelial Ovarian Cancer, a Natural Experiment in a Complete Population. They have got the entire patient denominator at the centre, and what the paper describes is a movement from a mixture of primary surgery and neoadjuvant chemotherapy, okay, to a upfront primary surgery maximal surgical ethos. All right. And what they discovered, having spent a large amount of time, large amount of resources, training and developing their skills, is that there was no difference in survival before and after such a change in surgical paradigm. Okay. And as they say, despite a substantial increase in the complete resection rate after the ultraradical surgery was implemented, it didn't improve survival in women, in this case with advanced ovarian cancer. And in fact, they noted a worse survival for many women treated surgically in the second cohort. And this in many ways an extraordinary and disturbing finding. So there's quite a bit of dark in ultraradical surgery, okay? It uses quite a large amounts of resources. There's variations in studies regarding the outcomes, really, which we see and how we assess disease. There's surprisingly low complication rates if people are operating across the whole spectrum of women which have got ovarian cancer. We've got limited quality of life data. But most importantly is that a lot of the studies which go on for driving this change don't have denominator data, meaning it's slightly difficult to actually draw meaningful conclusions for us to make the best decisions in order to improve the survival of our patients. So in conclusion, surgery influences cancer behavior. Yes, definitely, okay. Ultraradical surgery can now be performed safely, certainly. Okay, ultraradical services are becoming the standard approach to advanced ovarian cancer. Yes, they are, and I think they should be. Okay, removing the disease is the best way to maximum survival. What we need to look at is how we do that and still maintain good survival. The data driving this change is not transparent, and I think that is the big concern, okay, with how things are moving forward. We are extrapolating data from 58-year-old women and applying it to 80-year-old women, okay? And there's not a lot of data looking at these specific groups. People describe the range of patients. They don't describe the interquartile range of patients. You know, that 196-year-old who came in and had a pelvic clearance and happened to have stage 3 disease is incorporated with the people which had their diaphragm stripped, even though people, I suspect, would not consider stripping that patient. There's a lack of accurate information for patients in relation to quality of life and complications.